And I knew I just needed one slide or two after Jonathan, because it was impossible to do these two talks after each other without repeating things. So I'm going to skip through the slides that you just presented. And at the end of the day, you have to love statistics, and you have to have a lot of patience, and then you have to go one side or the other to close PFOs, right? Because I think, as you just pointed out, there's still criticisms. But what occluder device to use, I think I picked the two that are really studied the most and that are really available to us in the United States. You have a lot of strokes, and this whole discussion about closing the PFO is very simple. The patient is in front of you, has a cryptogenic stroke, and is afraid of having a new one. So that's the discussion that you have to have, and whatever other people tell you, now at least we have some data to support closing the PFO, and these are the two devices. So again, like Jonathan pointed out, 2017, big trials reported. Both or all three trials really showed that there is a significance. Again, I think that's just for statistics, because obviously there's not a lot of events in all of these trials. I think I just want to point out a couple things. These are usually the red markers here. First of all, for example, here in the close investigator trial, Germany and France, a lot of amplets or PFO occluders were used. So again, this is available to us. The others are really not. And that's important because it is the mostly used device in this investigation. But it's also important to point out, like Jonathan just said, there seems to be a signal for septal aneurysms and large shunts. So I mean, makes sense, right? So that's what we're trying to solve that issue. If it's really a small shunt, how likely is it that someone had a stroke from that? So that's one focus. Again, super small numbers, but again, statistically significant. One signal that I want to point out, I think Jonathan mentioned it, there is a little bit more atrial fibrillation in the PFO closure group. So I think you don't want to create a problem by solving one problem, right? So you probably have to watch these guys a little bit, because if you close the PFO and all of a sudden they have atrial fibrillation, even if it's just briefly after the implantation, but there is a signal, so be aware of it. The other trial that Jonathan pointed out or mentioned here, again, this is dedicated implants or PFO occlusion device. Same results. Freedom from stroke was better in the device group. And again, a substantial better effect for the larger septal aneurysm and the shunt. So I think that's important if you are in a PFO closure program. It appears that obviously when you're young and you have a cryptogenic stroke, that you benefit throughout your life from it. So that's an important point that they made. And again, they pointed really out that the large shunt and septal aneurysm is a very important anatomical feature. I think that in the beginning, when we were all trained in this, there are some operators that were always fearful of the Amplatzer device of erosions, and so there was a little hesitancy in some operators. But I think this trial also showed that we really didn't have that problem. So I think you have both devices available to you. Atrial fibrillation was again there also seen, but not necessarily significant. This DVT signal that was seen there doesn't really make a lot of sense to me. I bet it was some closure of the femoral groin. I just can't see that that's really an issue of the devices. Then of course the reduce. Like Jonathan pointed out, this is the softer version of PFO closure. The Cardioform device also, very nice device. I like it personally the most, but again, that's just personal preference. Again, same outcomes, low events, but statistically at least significant, justifying it now. They also analyzed new brain infarcts by imaging, also a reduction with closure. They also saw atrial fibrillation flutter, again, usually just in a few weeks after the deployment, but again, you don't want to create a problem by solving one. And when you look at the reduce folks, then they put this, of course, together to compare both devices. And again, you can look at one or the other side and decide what device you really like best. But I look at this and I say both devices are really good options, and it will eventually depend on your administration, really what device they're going to maybe offer you. I think, Jonathan, I congratulate and show this slide because it's really important. I think if you do PFO closure, don't just close people that have a PFO. I think it is a teamwork. You have to have shared decision making, but you should involve your neurologist. Do teamwork because then the decision making is much easier. If you close PFOs, you have complications, and then your neurologist in your institution wonders why you did it. I think that's just not good practice. So this is a really important slide, and you can see it everywhere. So just as a take-home point, I think both the Cardioform device now from Gore and the Amplatzer PFO closure device are really good devices. They all showed good results. Again, you can argue about the statistics, but they're both effective. They seem to be showing the best benefit in large septal aneurysms and large shunts, and the Cardioform device now is also safe in septal aneurysms, so you can really choose both. I would say you have to be a little careful with atrial fibrillation, so at least watch for it and make sure that you do some sort of screening. And I also suggest that you build a comprehensive PFO program where you have teamwork, as a neurologist, maybe even a hematologist, just to make sure that you're really treating the right patients. Thank you.